folks, for those of you who are maintaining your logbooks, just there's a little bit of confusion around, first of all, the Dropbox that I wanted to clarify. So you have your personal Dropbox account, which you are sharing with me. Now, that is in my folder. That's not your Dropbox account. So it's my Dropbox account, and your folder is a folder within my folder. And the reason it's a folder within my folder is because my folder is 2 TB. That means that you can store an unlimited number of files within the folder. It also means that you can alter your Dropbox within the folder, and I can actually check it without you having to take the file out and transferring it back in again. So how do you organize your folders? I'm just going to give you a very small example. So I'm just sharing my screen at the moment so that you can see it. So can you see my screen, everybody?
Yes, yes.
Excellent. This is Dropbox. This is my Dropbox. It's just coming up. Just have a slightly slow connection in Delhi at the moment, so I apologize about that. But just while I'm on that, can you see the logbook? Can everybody see the logbook?
Yes.
Yes.
Folders. Excellent. So each of your personal folders has a logbook like this. Now, you also have a logbook that's emailed to you. My advice would be that you can either use the logbook in the folder, in the Dropbox folder as is maintained over here. And for a start, what you want to do is fill your details in, your designation, who you are, where you're from. If you have a local mentor, you can fill their details in. If you don't, you can fill my details in, which basically is page 2. But most importantly, from our perspective, there is a section for some core competencies, which includes knobology, the ultrasound machine, your ultrasound machine. But then it has certain characteristics that you will learn. So some of you have already presented in the last 2 sessions, and you've been able to present anterior, lateral, posterior views, identify the bat sign, identify A and B lines. Now, as you've achieved that in the last session, or if you have put a file on the Dropbox and you feel you've achieved that, you just have to fill in the date here at which time you feel you've achieved that. I will review the videos from next Sunday onwards. And if you have achieved that, what I will be doing is putting my initials underneath over here. Some of you have joined late, so you kind of missed the first session. And I'm just repeating it again. What is very important is you do not have to insert any images in these boxes. These boxes are basically images that we have seen in peer review, or which you have uploaded to your Dropbox, and which, from my perspective, I would review every Sunday. Now, the place where you will have to introduce your Dropbox is here. Now, you will prepare cases as Microsoft PowerPoint images. And this is just an example. So 2 colleagues presented cases last week. So my expectation is that they number the case as 1, put a gestation and a weight in, why they did the scan, what findings there were. It doesn't have to be in explicit detail. I'm just showing you a model, kind of a logbook that's been kept by a colleague of mine. But more importantly, from my perspective, to insert the image, you would click in this folder, stored image, and you'll get a cursor over here. Now, in this cursor, if you wanted to insert something, there is a program to insert file, which I use this because minimize at the moment. But that program to insert file is here, right at the bottom, where you can see that I've clicked. And you have to go to Object. Now, when you click on Object, you will get a Create From file. Now, I would advise that you keep a folder on your desktop, numbering the cases that you can see in the background as 1, 2, and 3. And all you have to do is browse onto the desktop and then pick that file, which is a PowerPoint, and press Insert. Now, when you press Insert, it will ask whether you want to insert that as a file, a link to a file, or a display as icon. My advice is that you display as icon, and that name folder will get inserted over here. Now, the advantage with doing that is how you keep a log of all your files in a very simple way. It takes you maybe a max of 2 minutes to do, but at the end of each peer review, I usually encourage people to do it. Some people will end up doing 100 cases over the next 3 to 4 months. Now, it's impossible for us to review all those 100 cases. So my advice to you would be that you store the folders in the files, and clearly as we mark and maintain your competencies, if you feel that you've seen a pneumothorax after, say, 7 weeks, you would PM me separately in my WhatsApp account and say, Alok, I've done it. This is the date. This is the case number. It's uploaded onto my file. Can you open it and can you have a look at it so that you can sign off my competency? And what you would do is you would just date and sign off that competency over here. So if you diagnose a pneumothorax, that's the date you actually watched it in the video, observed. In terms of supervised, that's the date you actually got the scan image. If you want, you can link it to the case in your log at the bottom. It's up to you. I need a date, the date you did the scan. Once I've seen the scan, I will then put my initials at the bottom over here, and I will say that you've actually done it. If you are able to demonstrate this like 3 times or 4 times, then that's consistent enough for me to say that you're competent enough to perform this under indirect supervision. That would be after your credentialing at your local institute. So just to give everybody an idea, are you relatively clear about that? Does anybody have any doubts about that?
No.
It's very simple. It's very simple. So just having admitted everybody else, I'm going to stop my screen share. And I'm just going to share what your Dropbox should look like, just to make it easier for me and you. So can you see my screen now?
Yes.
Okay. So I'm just going to go out of the logbook. For those of you who live in Delhi, my part of the world, you probably realize that internet is quite challenging compared to Abu Dhabi and the rest of the country. I'm going to stop share so that Abhijit can now share his folder. So Abhijit, go for it. The stage is all yours. Just while he's doing that, I am just going to give an introduction to Dr. Abhijit Bhattacharya. So Dr. Abhijit Bhattacharya and myself have worked together in Southampton. Abhijit was a medical training initiative fellow with us, who spent 3 years with us in Southampton, working as a senior fellow. He's now moved to Glasgow, and he's working there as a locum consultant, as well as a point of care ultrasound fellow, where he's doing his work predominantly on neonatal hemodynamics. But me and Abhijit started our lung ultrasound training together, and pretty much, just to give you a flavor, we're actually peers in that when we created the first lung ultrasound training protocol, we did that together. We did a lot of peer review of our scans together. And again, for those of you who are training in groups, I can't emphasize enough how lucky you are to actually have people who can actually train with you in the same place because you can actually help peer review each other's scans. Abhijit is also very, very good with his IT skills. And in particular, I'm sure you're going to enjoy his talk today. His focus is going to be the normal lung, its appearance, a little bit about nomenclature, something that we plan to cover in terms of lung profiles. And then he will probably wind up giving you a little bit of a flavor of the different lung ultrasound signs. So what we're really going to cover in a lot of detail today is the normal ultrasound of the lung.
Can everyone see my slides now?
Yes.
Yes.
Thank you, Alok. Yeah, you're giving the introduction already, so I'm not going to repeat that. And maybe I haven't said this enough to you, Alok, but thank you very much. Alok has been a friend, guide, and a sort of a mentor for me for the last couple of years. He has helped me in more than one ways. So a lot of gratitude and thank you to you, Alok. Right. So without any further ado, we'll just crack on with today's session. Right. So I like to say this, most of the time when I'm doing this, we should not be limited with our, the senses, the biological senses in terms of evaluating the pathologies in this day and age. So like, in the last couple of decades, we have used stethoscope as the extension of our sense in terms of listening and trying to figure out the pathology we are dealing with. Now it's a time for the lung ultrasound, use of the ultrasound technology as the extension of our senses to find the pathology, to diagnose the pathology and individualize the treatment. And this is true not only for the lung ultrasound, but as a point of care ultrasound as a whole when we are using it by the bedside. So yeah, so it is just an extension of our senses. And I think in near future, I'm not sure it's going to completely, replace stethoscope, but it's going to be a part of it. And we are doing using the lung ultrasound machine with our ward rounds in Glasgow. So yeah, we are already using an extension. Now, I'm sure that many of you has always been asked this question, and I've been asked, and is the lung ultrasound a useful tool or is it an unnecessary gimmick? And to be fair with my colleagues, it's a very fair question. Yeah, we have been using chest X-ray for last couple of decades, and we have been doing fine. We are doing absolutely fine in terms of diagnosing and treating the babies, diagnosing TTN, RDS, and all other myriad of pathologies, and we've been doing fine. So it's a fair question. Why do we need another modality, diagnostic modality, to diagnose the same diseases? And it's a fair question. And I think I do not have to sort of convince you people, since you're already on the course, to learn it. So you guys are convinced enough that it adds to the information we are seeking in terms of diagnosing and individualizing the care for the babies. And lung ultrasound is is in terms of sensitivity and specificity, it's sort of outrank the chest X-ray. So. And this is not me saying it. There's no dearth of evidences now. I mean, there's a plethora of evidences in the literature world, saying that the lung ultrasound is quite superior in diagnosing, be it TTN, RDS, pneumothorax, pneumonia, and whatnot. So yes, this is a useful tool, and this is not an unnecessary gimmick. It gives us much more information to tailor our treatment for the babies. So it is better than a chest X-ray. But is it going to replace the chest X-ray? Well, not really at this point of time, because we're still learning, and because we have been using chest X-ray for quite decades, and the contemporary teaching is always trying to diagnose the pathology on the chest X-ray. So it will take time, but eventually we will be using more of the lung ultrasound, cutting down on the radiation to the babies and the chest X-ray, and that is the goal at the moment. So we're working towards it. And in our unit, we are we are happy that there are a lot of people on board with the lung ultrasound, and we have been called multiple times for all the cases pertaining to the lungs to do the lung ultrasound beside doing baseline chest X-ray. So we have been able to cut down on the radiation to the babies. So we are getting there. So this picture, I don't know if you have seen this picture, but this is an old or the first ultrasound machine. And you can see it's quite big. The subject is put into the water to get the ultrasound done. And I can proudly say that the ultrasound as a diagnostic modality has been the Glasgow has pioneered that. So Glasgow is the city where we have started doing the ultrasound. The first ultrasound was done on a pregnant lady to see the fetus. So the fetal head. So it all started in Glasgow, and we are making quite a progress here. And as I was happy to share that we have been working in the unit as a team to put things in place to get more of the ultrasound done and the rest of the chest X-ray. So we have come a long way since then. So this was in 1960s, if my memory is serving right, and we have come a long way since then. So this was the this was the kind of an ultrasound machine we used to have, and from here, you can see now it's all handheld. So this is a V-scan from GE, and this is all you need. It is quite small, handheld. It still has got a large footprint as compared to the extremely preterm babies, but we can work around it, and we do get the information we need in terms of the point of care ultrasound is concerned. So this is the size we have come down to. Right. So having said that, so what are the objectives for today? So we're going to touch base with the physicsology. We're going to do, I'm not going to teach you the whole physics, but we're just going to touch base with physics 101 with the ultrasound waves. I'm sure Alok must have, spoken to you about this, but we're just going to touch base. We're going to do some profiles recap, and then we'll talk about the pattern recognition. Now, lung ultrasound is quite gross as compared to the other ultrasounds. Talk about the abdominal ultrasound or the echocardiography. So there we see organ, but in lung ultrasound, it's more of the study of the patterns, because we do not see the lung and the lung ultrasound. We create artifacts and patterns. So it's all about the pattern recognition with different pathologies and in the clinical context to come to a conclusion. We're going to talk about signs in air leaks and signs in collapses and consolidations. So a little bit about the physics. So what is the piezoelectric effect? What is the frequency and the wavelength? How it impacts the scan you are doing, or how you're going to choose your probe? What is acoustic impedance, attenuation and absorption, and what kind of signs and artifacts it gives, and the basic ultrasound language of echogenicity. It is a dark, a grayscale, dark or white images, and that's the basics language of the ultrasound. So we're going to talk all about that. Piezoelectric effect. I'm sure you guys all know about this. So the ultrasound, in the probes of the ultrasound, we use the piezoelectric. It's a crystal when you apply, when you're applying the electricity to this to the piezoelectric crystal, it releases the ultrasound waves. And in the reverse, when the ultrasound waves come back, reflected from the area of the interest, and it comes back and hit the piezoelectric substance, it creates the electricity. And that is all about it. So the amount of ultrasound waves which is being reflected, or the amount which is not being reflected, is read by the machine algorithm as the bright image or the dark image. So you end up getting a grayscale image on your screen. So this is how the ultrasound transducer looks like. It's quite boring. I'll not spend too much of time on this, but you can see the arrangement of your piezoelectric crystals, which transmits the ultrasound waves and receives the ultrasound waves as reflected by the body. Frequency and wavelength. So Now, this is very important to understand from the perspective of what kind of a probe we choose depending on the area of interest we are scanning. So again, I'm sure everyone knows this. This is very, the 101 of the art of the waves. So on your left, you have your short wavelength and high frequency. So the wavelength is the distance between the wave as depicted by this area. So if you have a shorter wavelength, your penetration capacity of that particular wave comes down. So you cannot penetrate deep inside the body. So as you have a shorter wavelength, you have a higher frequency. So it comes in. So basically the frequency means the amount of waves being dissipated per second. So if you have a higher frequency, you get a high resolution image, but at the cost of losing out on the depth of the image. And it's completely opposite when you have a long wavelength. So if you have a long wavelength and the low frequency, you do get the higher penetration. You can see the deeper organs of the body, but at the cost of the resolution of the image. So you do not get a very clear image. And we can use that thing in deciding what kind of a probe we're going to use depending on what part of the body we are scanning. And this is the graph which shows you the different probes, different probes with their different frequencies, and you can see when you have a lower frequency probe on this side, which are the phased array probes. We particularly use the phased array probes for the echo, trying to see the deeper structure, looking deep in the heart and the vessels. So you can see you have a lower frequency, so you get a lower resolution. So this side is the lower resolution, but you are having a higher penetration, so you can go deep inside the body to look into the organs. But as your frequency increases, so you lose out, your frequency increases, you increase the resolution. So it's more like looking at the high resolution TV. So you get increase in the resolution, but at the cost of the penetration. So you cannot go deep inside the body. So you choose, if your organ is superficial, so you tend to choose the higher frequency probe. And as you can see, the linear probes, it comes between 5 to 15 megahertz. And that's the probe we want to use for the lung ultrasound, because lung is very superficial. And we are only looking at the pleura of the lung, and you don't go beyond that. So somewhere between 2 to 3 centimeter or 4 centimeter at max. So you lose on the penetration, but you get a very high resolution image. Now, acoustic impedance. When we talk about the impedance, it's basically the resistance faced by the ultrasonic waves. So which creates a reflection and the refraction. So when the ultrasound waves propagates through the medium, the resistance offered by the medium will have an impact on the ultrasound waves. So it will end up reflecting. So if it is a very dense medium, say for example bone, so bone will absolutely reflect everything that hits it, and all of the waves will be returned back to the transducer. So all of the waves are coming back, so you will get a bright image on your screen. Yeah, so it has a very high resistance, so a higher impedance. And then if the impedance is low, some of the waves will pass through and some will be refracted. Yeah, it is. You can imagine, the ultrasound waves propagating to the soft tissues, the fluid interfaces. In those cases, there will be the refraction. Not all of the waves will be reflected back to the transducers. Some of it will be reflected, and some will just refract. It will change the angle of the waves, and that will give you a lower brightness, more towards the grayer scale. So that's the acoustic impedance, and it is reflected here. So you can see as your resistance or the impedance of the medium changes, you'll end up getting some reflection, and there will be a degree of change on your waves hitting the medium, and that will lead to a refraction. The change in degree here is your refraction, and anything that is reflected back is your reflection. Yeah. What is attenuation and absorption? Now, and again, when the ultrasound waves are passing through a medium, So there will be a loss of its energy, and which is like, we are trying to walk on a swimming pool, so you need more energy to walk through that, in the water, be it swimming pool or or by the the beach side. So as we need more energy, or you can say with the same energy, you need more effort to walk in water. The same thing with the ultrasound waves as well. So when it's passing through the medium, so depending on the viscosity of the medium, how dense is the medium, it loses some of its energy, and that loss of energy of the ultrasound waves is attenuation. Yeah. And this attenuation, the loss of energy, gives us something called as shadowing artifacts. So shadowing artifacts, we like to call it as a rib shadow or a bat wing sign, which is one of the pillar in the ultrasound waves in identifying that we are in a right position, right location. We are doing it right before we made an interpretation of that particular scan. So it will give you a shadowing artifact. And we'll talk more about it and explain to it further on the slides. Now coming to echogenicity. Now, echogenicity is, again, it's depending on how much of attenuation and absorption is going on with the ultrasound wave. And it will give you either black, pitch black, or a bright image. And that's the basic language of the ultrasound. So anechoic is absolutely black. And as you can imagine, as I have shown on the first image where the ultrasound scanners were quite big and subject has to be inserted in water. And that is because the water is a good medium to propagate the ultrasound waves. So there's a very, very low attenuation and low absorption of the ultrasound waves when it passes through the liquid medium. And hence the water was used. And how do we do that nowadays? To cut down on this attenuation and the reflection of the waves from the air, which is a very it's not a good medium for ultrasound waves. It reflects all of the ultrasound waves. We try to use this gel to kind of limit the gap between the the transducer and the skin. So it makes it removes the air barrier basically to help propagate the ultrasound waves. And you can see you can see, can you see my cursor, anybody? Or
Yes.
okay. Yeah. So as the probe is held here, and you can see it is passing through the soft tissue, and there will be some reflection. So you can see some, the white image here. And as soon as hits the fluid filled sac, so this is a bladder, and you can see it's filled with urine. So as soon as it hits the liquid, it just propagates without any hindrance. Sorry about that. Without the hindrance, so there's minimum of reflection here or minimum of a refraction here. So you end up getting a pitch black image here. And then further, it hits the posterior wall of the bladder and whatever the structures behind it. So this area is anechoic. So it is not echoing back to the transducer. So anechoic, pitch black. And from here all the way to the hyperechoic, there's structure which is reflecting all of the ultrasound waves back. So that will understandably will give you bright white image. So bone is the brightest. And in our context, when we're doing the lung ultrasound, when you are hitting the pleural line, it becomes, so pleural line is hyperechoic. And the reason for that is very simple. The lung is air filled, it's an sac filled with air. So beyond the pleural line, it's all air, which is non-conducive. It's a non-conducive medium for the ultrasonic waves. So everything gets reflected back to the transducer. So you can see the pleural line appears as a bright white line. Beyond this, it's all air. So it's not gonna penetrate the air medium. So it's gonna go, all of the waves gonna hit back to the transducer. You see a bright hyperechoic line. And anything in between of that will give you either hypoechoic, as you can see in the picture here, that's your liver and that's the right kidney. And this appears darker than the kidney. So hypoechoic compared to this right kidney. Or it can be isoechoic. As you can see here, the spleen and the kidney is looking similar in terms of, the grayscale language is concerned, or the grayscale is concerned. So it looks of the similar echogenicity. So Anechoic is pitch black, hyperechoic, bright white, and anything in between can be isoechoic or hypoechoic. Now we have, as we know, we are convinced that we do it, how we do it, what's the physics behind it, why do we need to do it? So point of care ultrasound, lung ultrasound is very limited. It is focused and it is bedside, always done by the clinician. So say, for example, you are dealing with a baby which is a late preterm born or early term born, and mom had just incomplete steroid, one dose of a steroid, and now baby is huffing and puffing, and you have put the baby on a CPAP of 7 or 8 centimeters, requiring about 29.5% of oxygen. So you haven't hit that 30% mark to give this surfactant, although there's been incomplete steroids. So what are you going to do with this baby? So you've done a chest X-ray, and in chest X-ray it looks a bit hazy, maybe some sunburst appearance on the chest X-ray, indicating more to a TTN, but it's at the same time it looks homogeneously, fluffy opacities on both the lung areas, which might be a moderate RDS as well. So how do we know are we dealing with a TTN or a RDS? So in those kind of scenarios, the chest X-ray is sort of unambiguous in giving you the right diagnosis. The ultrasound will give you the bang on answer, like are we dealing with TTN or are we dealing with the RDS? Of course, with the clinical context and the clinical background. So it is clinician performed, and it helps you tailor or individualize care for the babies. Yeah. So it is always performed in a clinical context to answer the specific questions in real time, and it guides care. Yeah. So you avoid doing multiple X-rays. Some people might, if you don't have an ultrasound lung ultrasound skill, you might want to wait, for another 1 hour, repeat an X-ray, or see clinically baby's oxygen requirement is going up. You end up giving the surfactant to that baby. Or some people might say, okay, 29.5%. Okay, let's consider that as a 30% and give some surfactant. Or, after 2 hours, you can see, on the CPAP of 8 centimeters, baby is turning corner, oxygen requirement is falling down, and you think retrospectively, okay, we are dealing with the TTN in this case. But with the lung ultrasound, you'll get the answer then and there by the bedside. Now, how do we do it? As I said, lung is just a sac filled with air. It's a simple organ. It is unlike the heart or the abdomen, which contains 20 odd organs in there. So doing echo is quite, it's complex. It's a complex structure, blood flowing in all directions, and you have to have this spatial orientation in terms of how the heart looks if you are trying to echo it from the apex or the base, or in different sectors. So it's quite complex, and you need a lot of time to master the skill for the echocardiography. And same for the abdomen as well. It's quite complex with different organs there, 20 odd organs. But in contrast, lung is quite simple. It just has, it's just a sac filled with the air, and it just has a pleural line, and it gives you different kind of an artifacts. So it is very gross compared to the other ultrasound modalities. So we just have to identify the pattern, generated by all the artifacts. All the signs arises from the pleural line. Yeah, as I said, you do not see the lung in the lung ultrasound. Yeah, all of the signs are arising from the pleural line. So always the first question when we are doing this scan is to talk about the pleural line. Do you see the pleural line? Is it moving, not moving? Is it like dynamic or not? So we're going to address all those things in the upcoming slides. And lung signs are mainly based, as I said, on the analysis of the artifacts, and it's a dynamic organ. So lung, with the breathing movement, inspiration and expiration, it is moving, it's dynamic, and so are the signs. So when we are doing lung ultrasound, we never took a snapshot of it. We always do 2 or 3 cycles video. And that's the reason for it, because lung is dynamic and your signs are dynamic. So you need to take a video of it rather than a snapshot, because you cannot interpret a snapshot. Now, when we have decided we're going to do it, we know how to do it. So we have to choose the probes as well now. And as I said, depending on what we are dealing or what we are trying to scan, we choose our probes. For the lung ultrasound, see, we can use any of these probes, but the best resolution will be delivered by the hockey stick, which has the very high, 15 megahertz resolution, and you can use the linear probe as well. Having said that, you can also use the phased array, and in some situations, curvilinear as well. But the preferred probe would be a hockey stick because it is a very small footprint, and the kind of as a patient we deal with the extreme pretermers and the preterm babies or the IUGR babies, we need something with the smaller footprint. Or you can use the linear as well. In linear, I quite like the linear because it gives you, in the preterm or a small babies, it shows you in entirety. There is no difference of R1 and R2 zones, so you see the entire lung, and it gives you quite the good view of the artifacts in one go. So less handling time with the babies, and quite understandably, those are the fragile babies. You don't want to upset them for long. Right, so probes. The phased array probes have a great penetration. Hence, as I said, we can use this for the echocardiography. It has an okay resolution and it has a small footprint as well. When we are dealing with the curvilinear probes, it has a very good penetration. As you can imagine, this has a lower frequency, higher wavelength probes. So you get kind of a good resolution, but not the best resolution. And this is the most versatile probe. As I said, you can use any of the probe. So you can use the curvilinear probe as well, but it will give you a good resolution, but not the best of the resolution. And your linear probe or the hockey stick probe has a very poor penetration. They are the high frequency, low wavelength. So they have a very poor penetrating capacity. And so what we want in the lung ultrasound, it's a quite superficial organ. So we need just a depth of 3 to 4 centimeter, and it gives you great resolution, like a high definition television. And just to reiterate the fact, this is how we choose from the low to high frequency, depending on what's the resolution we are getting and what's the penetration we are getting. Now let's talk about the artifacts then. So there is something called as reverberation artifact, acoustic shadowing artifact given by the the attenuation. Then there is comet tail artifact and mirror image artifact. So reverberation artifacts gives us two lines. We have talked, you must have seen A and B lines, talked about A and B lines so many times. So it is given by the reverberation of the ultrasound waves. It reverberates. So the horizontal reverberation, when the ultrasound waves are moving horizontally between the, your probe and the area of scan, it gives you A lines. And if it is reverberating vertically, it gives you the B lines. And what do I mean by that? So you will see in that small snippet here. So this is a soft tissue area, and then the bright line is your the pleural line, and and the bright lines below those are the A lines. And A basically means air, very simple nomenclature. So you can see this bright line as a pleural line, and below that is your air-filled lung. So any ultrasonic waves hitting the pleural line will be reflected back to the transducer in that manner. And that will create, say that the T is the transducer here, and it takes a T amount of time to hit the pleural line. So it will, whatever that time is, and it will create an A line, which you'll see in this on your image or your scanner. The following the ultrasonic waves will come, it reflects the transducer, come back to the pleural line and go back to the transducer. So it will take twice the T time. So the scanner thinks, it is reflecting another pleura at twice the amount of time. So it will give you another A line. So that is the way the A lines are formed on the ultrasound scanner. So pleural line, reflection of the wave, A line, reflection further, twice the time, another A line. So it will always be equidistant. If you see from the transducer to the pleural line, whatever that distance is, you will see the similar equidistant between the A lines and the pleural lines. It will always be equidistant. So that's how the horizontal reverberation gives you the A line. I hope that makes sense. And we'll see. Sorry about the clumsy kind of animation here, but you can see the lines are reflecting back and forth between the your probe and the pleural line and multiples of times. So one reflection gives you the pleural line. The second reflection taking twice the time is giving you the first A line here. The third reflection taking the thrice the time is giving you the second A line here. So that's how the A lines are propagated here. Yeah. And this is your horizontal reverberation giving you the A lines. Anybody like to comment on this? Okay. So again, so pleural line, hyperechoic pleural line, and your A lines coming at equidistant intervals. Pleura, A line, similar distance. As you can see, you can eyeball it. You can see similar distance from the probe. This is the soft tissues, pleural line, A line, equidistance from the transducer to the pleural line. And because of this, in a normal lung or in pneumothorax, you can get something called as a bamboo spine appearance. The radiologist, or the sonologist have a very stretch of imagination. So because I can understand, they deal with the gray images and it's all black and white. So you have to stretch your imagination. You don't see color. So they come up with all this imaginary things, but I'll give it to them. It do looks like a bamboo spine. If you have seen bamboos, it looks like a bamboo. And I'm sure you guys will agree with me. So you can see pleural line and all the A lines forming all the way to the bottom of the screen, and it gives us. It looks like a kind of a bamboo, So bamboo spine appearance, or you can say that this is a spine with the vertebral bodies. So yeah, bamboo spine appearance. It can appear in normal lung, or you can see a very exaggerated of this sign in the pneumothorax as well. And then let's talk about the B line, how the B lines are generated. You can see here, again, this is a pleural line, hyperechoic pleural line, and then there's a vertical lines arising from the pleura, reaching all the way to the bottom of the screen. Yeah. So, and these two are the ribs over here. And how these are created? So this is a alveoli, which is fluid filled because of the pathology, surrounded by some air. And as we understand, fluid is a good medium for the propagation of the ultrasound waves. So it will move unhindered. But at the same time, air is a very bad medium. So it reflects. So the fluid reflects, it bounces all over the place, and it gives you a vertical hyperechoic line, which we call as a B line. And rightly so, we see this, as you saw, it's a fluid filled alveoli. So you will see this sign when the lung is replaced by fluid. The air has been replaced by fluid. And depending on how much of fluid is there in the interstitial space or in the alveoli, your amount of B lines will change. Yeah, you will, if it is a dense looking lung, wet lung, you might end up seeing a completely white out picture, which is, the combination or the coalitions of the B lines. Or if it is a normal lung, you expect to see some degree of fluid there, interstitial fluid, you will see, 2 or 3 B lines. So that's how the B lines are generated. We'll come to the differences and where do we see B lines and what pathologies, what it looks like in the upcoming slides. So again, you can see, so those are the ribs. This is the pleural line over here. And then you can see your A-line equidistance from the pleura. At the same time, you can see these vertical horizontal lines, vertical lines arising from the pleura, reaching all the way to the bottom of the screen. It comes and goes. You can see momentarily it comes. There you go, reaching all the way to the end of the screen. So these are the B lines. And this lung looks pretty normal to me. It's mostly A lines, and there is, you can count the B lines as they are appearing. So, one B line here, you can see two more over here. So that's a normal looking lung. Right. Let's talk about the acoustic shadowing artifact. Yeah, so I have put some color in here for you guys now. We're tired of seeing the black and white. So acoustic shadowing gives us a bat wing sign. So why bat wing sign? Again, guys, stretch your imagination. Try to find the bat on the picture. So here you can see the rib, which will reflects all the sound waves if it is a mature rib, fully calcified. If not, you can imagine it will let some pass, but nonetheless you will get some kind of a shadow here. So the rib, reflected waves, and beyond this will be a shadow because all the waves have been reflected, so you get a shadow. So two ribs, two shadows. Yeah. And then here is your pleura, which is reflecting the sounds back here. So horizontal reverberation, and equidistant, you are getting A lines. All right. I have taken this image from the POCUS 101 website, which you guys also can see and read. They have a plethora of information there with the nuances of the ultrasounds. But here they have written lung tissue. Just ignore that. We do not see tissue. If you're seeing the A lines, you do not see any lung tissue. It's all artifact. There's nothing in here. It's just air. Right. So now Lincolnstein came up with this name, the batwing sign. And why the batwing? And again, guys, try to imagine it. I'll try to superimpose and try to show you the batwing here. So that's the bat. Yeah, that is my bat. You can see the body, over the pleura, and these are the A lines. Just imagine A lines. Yeah, going all the way to the down A lines. And then because there will be a rib over here. Oh, as you can see, there's a rib on both the sides. So it's going to reflect all the sound of it back to the transtissue. You end up getting a shadow. So that's where the wings come in, shadow of the wings, and that's your bat wing sign. Now, this is a very important sign. So whenever we are doing the scan, when you're learning to do a scan, you can see as you move your probe, you do the sliding movement, rotation movement, angulation of the probe, the image quality changes quite a bit on your scanner. So you might think like, okay, it looks more aerated when I put in a particular position. Whereas, when I move or change the angle of the probe, it looks more kind of a wet lung. So which one am I interpreting? Which image am I interpreting? Am I getting the right image or not? Or, is it a well aerated lung? Or, with a change in the angle of the probe, it looks more of a dense lung. So what am I saying? So to correctly interpret, to take that, observer effect out, or, to know that you are at the right angle on the pleura. So you have to be absolutely bang on right angle, 90 degrees over the pleura. How do we know that? You have to be able to see the bat wing sign. Yeah, you should be able to see the clear ribs, rib shadows, yeah, clear pleural line. And then when you see this, then you know we are at 90 degree over the pleura, and this is the image you interpret. If you make slight angulation movement, either you're going to lose the shadow, yeah, and you might be seeing more of a B line as well, because it depends on how you are propagating the ultrasound waves onto the lung, or rather onto the pleura. Right. So as I explained those already, pleural lines, rib shadows, and A line. Let's talk about the comet tail artifacts, which is also known as the lung rockets. Yeah, so quite inventive names here. So I've tried to put small pictures, animated pictures here to show some kind of a similarity on the comet tails and the lung rockets. So you can see over here, the best way to imagine comet tail or the artifacts is the incomplete B lines. Yeah, so that's the difference between the B lines and the comet tail. So B lines reaches all the way to the bottom of the screen, as you can see in the still image. I will play the image just now. So from the pleural line arising vertical reverberations reaching all the way to the bottom is your B line. If it doesn't reach the bottom of the screen, if it ends midway, that will be your comet tail artifacts. Yeah, so like the tail of the comet, it's ending in the midway, or the the exhaust, the flames of the rocket. So we can imagine that it is not reaching the end of the screen. We will call that as a comet tail artifacts. And comet tail artifacts and the B lines are kind of a surrogate marker for you guys. When you are seeing this, one thing you can absolutely rule out, and that is pneumothorax. Yeah, as I said, there has to be some fluid and air interface to generate this kind of an image, to get this vertical reverberation, or to get the comet tail artifacts. So what that basically means, there is some lung there which is harboring that fluid filled sac. So alveoli is there. So if the lung and alveoli is there, it's not pneumothorax. Yeah. So it's kind of a surrogate marker. So let's play the video, and you can see this small, vertical lines. It arises, you can see here, it arises from the pleural line, but it doesn't reach the end of this screen. Yeah. I hope you guys agree with me here. At the same time, these are the B lines. Yeah, looks like a focused light, on the opera. So it reaches all the way to the bottom of the screen, and these are the B lines. It terminates midway. Right. Another example. Again, small vertical reverberations, and arises from the pleural line, but it terminates midway. Yeah, it terminates here. So you're not reaching the end of the screen. Hence, these are the comet tail artifacts or the lung rockets, and they are not B lines. Then there is something called as mirror image artifact. So again, going by the name, you can imagine you get the mirror image of what you are seeing. Yeah. And as you can see here, so these are the ribs. Why it is looking black? I was saying that, bone are, absolute reflector, and you should be able to see bright. So it's not bright, it's appearing black. You can see some degree of whiteness here on top. And this is mainly due to the babies have, their ribs are not completely calcified. So you can be hitting at some point costochondral junctions as well, which are cartilage. So you will end up getting this kind of an rib shadowing. Yeah, you can see ribs like that. So you can see ribs, you see the pleural, bright hyperechoic pleural line, and you can see the A lines as well. Here you can see the ribs on the both side. You can see the ribs here, you see the ribs on the other side as well, which is clearly not true. You don't see ribs on both sides of the pleura. So this is called mirror image. And how do we get the mirror image? Is again the ultrasound scanner or the machine is getting fooled by the reflection of the ultrasound waves from the pleural line. So as it is reflecting all the waves back, as I have explained on the horizontal reverberation artifact giving you the A lines, at the same time it kind of create an image of the reflected it reflects the ultrasound waves from the pleural line, and it thinks the ribs are present on the other side as well, because this is what you see, it reflects twice. This is what you see here again, it reflects twice. Although it's not very clear, you'll end up getting a rib space or the rib shadowing over here as well. So that's what the mirror image artifacts. What this basically tells you, if you are getting such a high degree of reflection, there must be a interface which is reflecting 100% of the ultrasound waves. There is not a single ultrasound wave is able to pass through the pleural line. So there is no air air fluid interface present here, which basically means there is no alveoli filled with air, or the lung interstitium which is filled with air. Hence, it means it's all air in there. It is a kind. It is a sign for the pneumothorax. I hope that makes sense. All of this is making sense. You can see here, I'm playing the video, so ribs on both the sides and here as well. You can ask me a question. Well, Dr. Abhijit, you just told me that if you see the comet tail artifacts, or the B lines, that's a surrogate marker of there is no pneumothorax. I can kind of see both over here. Well, that is because you can see here there is a loss of a bat wing sign. Yeah. So what is wrong over here is my angulation. So I have not angled the probe perpendicular to the pleural line. Of course, there is some lung coming in the picture, which is from the adjacent lung. There will be some lung somewhere. The pneumothorax is not global thing in this baby at the moment. So there is a pocket of air somewhere which is reflecting all these waves. But at the same time, there will be a juxtaposed lung as well. So that is giving you this. So it becomes imperative that you get the bat wing sign before you interpret the image. I hope I have not confused you guys further. Again, you can see here, now this is not a lung scan. This is a curvilinear probe, as you can make out from the curve here. Yeah. And this baby, we were doing the lung ultrasound. We had a suspicion, not suspicion, we were pretty much sure that this baby has got a pneumothorax, and we are trying to figure out the extent of it. Yeah. So we haven't seen a lung point in this baby. I'll talk about the lung point also, but we are trying to find the lung point to figure out the extent of the pneumothorax. So we use the curvilinear probe to go a bit deeper and see, what the basal pocket look like. So this is your liver, and the capsule of the liver, and you can see on the other side, you can see the liver again. Normally, the liver should look like this. Yeah, you see the liver, all the vessels, portal vessels, and you see the vertebral body, your aorta, and your the IVC. Yeah, this is how it should look. But here you can see kind of a liver you're seeing on the both side. Again, mirror image. Why we are seeing liver on the both side? Because here it is filled up with air. So it is reflecting all the waves back. So you can see liver on both sides. So basically, on this particular baby, we didn't see a lung point, and it was a massive pneumothorax we were dealing with. Okay, so we've seen some signs, some artifacts now. So just to talk a little bit about the lung preset and the settings, I'm sure Alok must have spoken about it, or he will speak about it, multiple times. But if you have seen this, it's a slight repetition, but just bear with me. It will consolidate of whatever you have learned so far. So in terms of choosing the mode or the preset, we need superficial or a muscular preset on the machine. If you have newer machines, newer GE machines or the Philips, they do come with the lung preset. If you don't have it, don't worry, just choose superficial. So we need to see the very superficial part, where it will give you a depth of 3 to 4 centimeter. That's what we want. Yeah. Focus. Where do we keep the focus? When you are trying to play around with the focus, if your machine allows, then you want to keep the focus at the level of the pleural line. As I said again, every artifacts are generated from the pleural line. So you are trying to focus everything on that part of the image to get the best resolution. So focus at the level of the pleural line. Depth, as I said, we will keep 3 to 4 centimeter. 3 centimeters quite more than enough in extremely premature babies, less than 1,000 grams. More towards the term babies and big babies, you want to keep it at 4 centimeter. What will be the width of the the sector of the scan? So you want to keep at least 2 intercostal spaces. Yeah. So why we need 2 intercostal spaces or 3 ribs? Again, to identify the bat wing sign. Excuse me. So we need at least 2. You get more than this, with your linear probe. Yeah, nothing like it, but at least you should be able to get it 2 intercostal spaces. And gain. So gain, I like to say, I like to think gain as, how uniformly the bright your image is. I will not go into the the nuances of it, the nitty-gritty of how you change the gain and all that. I'm sure Alok will talk about that. But just to think how uniformly bright, you should not be seeing images in some areas it's like absolutely going deep black, just beyond that area or around that area you're getting a bright image. So it should be uniformly bright, and the best way to do it is to hit the eye scan button. Most of the new machines have that, so it's figure out on its own the optimal gain setting for the area you are scanning. And very, very important is your harmonics. We want to switch it off. We do not want harmonics. Yeah. So harmonics, you can imagine it's harmony. It tries to create the harmony in the image. Yeah. Basically, the machine is trying to remove all the artifacts. So when you are doing echo or you are trying to do, abdominal ultrasound, you don't want to be bothered with the artifacts because you want to look at the organ rather than the artifacts. So you do not want harmonic. You do not want the artifacts. So you switch on the harmonic settings, yeah, and machine will try to eliminate all the artifacts that is being generated. On the contrary, when we are doing the lung ultrasound, as I said, we do not see the lung. Everything is reflected from the pleura. So we are trying to look at the artifacts. So you do not want machine to remove the artifacts. It will change everything. So be mindful if it, as I said, if it is a new machine, it has come with a lung ultrasound setting, harmonics will always be switched off. If you don't have it, if you're using a superficial or a muscular mode to scan your lung, scan your baby, then be mindful that you need to switch off the harmonics. Top tips to get the good images. So again, I'm not going to spend too much time here. You can see the baby's position is very important. As in like we will talk more about it while we are dealing with the RDS and all. Some units like to keep the babies supine position. Some units, as soon as the baby is put in an incubator, they put them in a prone position. And sometimes you end up getting, by the time the baby is settled and you are there with your scanner to image the baby, scan the baby, the nurses have already, immediate at that, just before that, prior to that, has turned the baby from supine to prone or the other way around. So it becomes important how the baby was positioned when you are interpreting the image. As you can imagine, if the baby has been put supine, for 1 hour, on a CPAP, and you have come to scan the baby, by the virtue of the gravity, whatever the fluid was in the lung has gravitated towards the basal portion of the lung, and that would be the back portion of the lung if the baby is supine. It will be role reversal when the baby has been put in a prone position. Yeah, so it will gravitate more towards the front of the chest because baby is prone. Now, if the baby was put supine, you come to scan the baby, and baby has been put prone just prior to that. You will see more wet and more of a beelines on that image, on that baby. So it becomes very important how the baby has been positioned, what position baby has been kept. At the same time, it becomes very important or imperative for the operator's position as well. Be comfortable while you are scanning, because when you're trying to scan the baby through the porthole, for a preterm babies, of course, or the term babies on a cot, we end up in fuzzy positions, having getting a catch on the back or the neck. So you don't want to do that. As we progress, we want to scan more and more babies, so don't wreck yourself basically. So be comfortable while scanning the baby. Use of the ultrasound gel pre-warmed. I can't emphasize enough here. When you're using a pre-warmed gel, you are not startling the baby. The baby is not upset. Will try to cooperate with you while you are scanning. On the contrary, if you put a cold gel on the baby, yeah, they're gonna throw tantrums at you. They'll not let you scan, and it will sort of compromise your image quality. At the same time, avoid putting a lot of pressure. This is what we have seen when we are training the trainees to do. Inadvertently, we have the tendency, because baby is moving, you try to, sort of fix your hand on the probe on the baby. So you end up putting a lot of pressure. You do not want to do that from the two perspective. One is you are trying to hinder, the breathing movement of the baby. If it is a preterm baby, that kind of a pressure it will not be helpful for the baby. So it will affect the respiratory movements. On the other hand, when you are squeezing too hard, you are sort of squeezing the ultrasound gel out of the lung and probe interface. So the air sips in. Yeah. So as soon as air sips in, you will get more of a reflection. Um, uh, you will get all sort of an artifact. You'll not get a very good resolution image there. So you don't want to do that. So put a reasonable kind of a pressure. Keep a light hand on the baby, and avoid squeezing out the gel. Always ask for help. I need help always. I've from my nursing colleagues, or if you have your doctor colleagues as well. Try to calm the baby, and giving sucrose gel while scanning them to calm them. So it helps you a lot. It changes the image quality immensely. And I don't know why it's happening all the time. Sorry about this. And the last thing I wanted to say again is about the ambient light of the room. And do not underestimate that as well. So if you are in a well-lit room by the window side and you're trying to scan the baby, your scanner is facing the window and all the reflections are coming from the window. In a bright sunny day, you will struggle to interpret the image, or it will give to erroneous interpretation. Yeah, so we don't want to do that, because your gain settings will be all wonky, because it's a bright light falling at the scanner, and you will feel like, oh, my scans are appearing quite dark. So you're gonna you'll go up gaining, put up the gain on the scanner, and by the time you go for the interpretation, or if somebody else is reviewing the image, it will look absolutely bright image. You'll not be able to make out much of the scanned area. So ambient light of the room becomes very important there. Right. Having said all that, let's talk about the lung profiles. Again, these are all pattern recognition, and it's very easy. As I said, it's very gross kind of an interpretation. So, and hence it needs it doesn't take long to learn lung ultrasound compared to the other, echocardiography or the abdominal scans and all that. So we'll talk about the A profile. We'll talk about A prime profile. We'll talk about the B, and we'll touch on the C as well. We'll not go in detail of it, but we'll just touch base with it. Right. We have discussed A lines already. So they represent air, A for air. Yeah. It's a horizontal, sharp, and discrete. It has to be repetitive and equidistant. It is sorry, that's not a vertical. That's a typo here. It's a horizontal reverberation artifacts, and all of the A lines originates from the pleural line. It can be found in the normal lung, or it can be found in the pneumothorax. So now when we know that, so when do we lose the A lines then? Yeah. So when air is replaced by the fluids. Yeah. As soon as your fluid creeps in, you start seeing B lines. Where do we get the fluids? You can see in all kind of pathologies, in RDS, alveolar edema, TTNB, all of this, you have some degree, more than the other of the fluids in there. So you will see less or more or compact coalescent B lines. Yeah, when we see those, you'll understand what I'm saying. Also, when your air is replaced by blood or exudates, like of infection or pneumonia, or when you deal with hemorrhage, again, it will give you B lines. You can see the B line doesn't changes. Your pathology is changing. So, but you are still getting B lines. If it is replaced by the fluid, well, the blood and exudates are also fluid. If it is just plain simple fluid, you're still getting B lines when your alveoli is replaced with blood in pulmonary hemorrhage, or having exudates from infection, pneumonia, you're still getting the B lines. Again, I'm emphasizing here, is the clinical context, the clinical background is very, very important. Yeah. So you cannot overemphasize that. So always interpret the scans with the clinical context, with the clinical background, because it will only give you A or B lines. So it can be RDS, or at the same time it can be hemorrhage. So how do we differentiate between the two? Clinical background will help you. Right. And air is replaced by collapses and consolidations. So you can imagine A is air giving you A lines. If there is a collapse of the alveoli, there is no air in the alveoli. Or infection has given you a consolidation. It has become thick, and gelatinous and proteinaceous substance are accumulating there. So your air is being replaced by that. So you don't see A lines. you will see rather, kind of a C profile or a shred sign, which we will talk about when we will go there, when we will discuss atelectasis and pneumonias and all that. But you can see these are the situations where your A lines are replaced. Talking about the B lines, trust me, B has nothing to do with this B. I'm just trying to make it colorful. Right. So what are B lines? It's a well-defined hyperechoic vertical lines rising from the pleural line. It reaches, again, sideways and vertical reverberation. Important difference from the A lines, from the comet-tail artifacts, that it erases the A lines. You will see when I show you the clips, it moves with respiration, unlike the comet-tail artifacts. It extends all the way to the bottom of the screen. Comet-tail artifacts terminates midway. Yeah. I've already said that if B lines terminates midway, you call that as comet-tail artifacts and not B lines. Consider the B lines as curly B lines of the lung ultrasound. That's where the B comes from. Yeah, it has nothing to do with the B. Yeah, so as we see curly B lines, which basically tells you there is a fluid-filled fissure on the chest X-ray. So again, fluid-filled alveolus on the lung ultrasound, we call them as B lines. I hope all of this is making sense. You guys with me? Now, is it normal to have B lines? Well, of course. If you have less than 3 B lines in one segment, then that's absolutely normal. When I talk of one segment, it's not one zone, it's just one segment, which is your, which comes within the ambient of the bat sign. So when you're seeing the pleura as interspaced by the or buffeted by the rib shadowing, so in that one segment, if you see less than 3 B lines, it's absolutely normal. Yeah, you expect to see some kind of interstitial fluid or some degree of fluid in the alveoli. It becomes abnormal, when it is more than 5 B lines. What about 3 to 5 then? Gray area, grayscale imaging, gray area. So it is absolutely abnormal if you see more than 5 B lines, or if you cannot count them, it has become coalesced or it has become compact. That absolutely, there's some pathology going in there. Coalesced or compact B lines is similar to white-out lung in chest X-ray. So you can imagine if you have a white-out lung in a newborn baby, preterm, early preterm, or maybe a late preterm, without the antenatal steroids, requiring CPAP support, or maybe going for an intubation. When you do the lung ultrasound, you will see when you see the chest X-ray, you will see a white-out lung, and you say, bang on, okay, that's RDS. Let's give surfactant. If you are doing lung ultrasound on that baby, you will see compact B lines. You will not see any B and any A lines. As I said, B lines erases the A lines, so you will not see any A lines. It will be all white out on the lung ultrasound. These are the differences between the B lines and the comet tails. You can easily differentiate. Keep just few things in mind, that it do not erases the A lines. Yeah, well, and you can imagine why, because it is not reaching the end of your screen. So if it's not reaching the end of your screen, you're going to see A lines somewhere. So it doesn't erase the A lines. Whereas B lines, it erases the A lines. Yeah. Comet tails do not move with the lung sliding. B lines do move with the lung sliding. But we'll not stress much about this, because if we are seeing, either of those, it's, we safely assume that there will be some degree of lung sliding will be present. Yeah, it may be less, but there will be some degree of lung sliding, which again, basically ruling out that there is a pneumothorax. Right. And then M mode. Any guesses why we say M mode? Well, that's a motion mode. It's a one-dimensional interrogation by the ultrasound wave. All this while we have been talking about the two-dimensional interrogation. And M mode is just the one-dimensional interrogation of the lung. So you see the lines. Yeah, basically you just see straight lines. So in M mode, if you are dealing with the air interface, we see something called as barcode or a stratosphere sign, which basically tells you there's an air leak, or in other words, pneumothorax. We're going to talk more about it. I'll show you the signs. And if you see if you do M mode and there is an air fluid interface, which is basically in a normal lung, because there will be interstitial fluid, if not alveolar, then you will see something as seashore or a sandy beach sign, which is a normal lung. Again, we will talk about it. I'll show you what I mean. And if you're doing an M mode in a baby who has got a fluid interface, there's no air, just fluid, which will be in pleural effusion, you will see something called a sinusoidal sign. Again, we'll discuss in detail when we deal with those. Right. When we're doing the M mode, just be mindful that when you are interrogating the lung, your cursor should not be over the ribs. Yeah, it should not be over the ribs. It should always be on the pleura. Yeah, in between the ribs. So you can see the rib shadowing here, the blackened area on both the side, and you can see the pleura. And I don't see any A lines here. It's all B, and we are interrogating here. So this is a kind of a image you generate when you do M mode interrogation of the lung. We'll talk in detail what we are seeing here. Right. Now, we know what the A lines are, what the B lines are, and we know how they are generated. We know what it means, what kind of a pathology can give you A lines, more A lines, what kind of a pathology can give you B lines, committal artifacts, um, and there will be a pattern coming to it. I'll show you all the patterns in the upcoming slide, but we have to keep a systematic approach when we are dealing with it. So all these are haphazard at the moment. So A lines, B lines, committal artifacts, and we will talk about all other pathological signs when we deal with the pathologies. But when you see all these signs, you have to make a system in your head, a mental model, that while we are scanning, we're not skipping step. So we are going step by not to miss any pathology or misinterpret this your scan. So what is a step-by-step approach? So first, we have to see, is there a pleural line? Yeah, we have to see a pleural line. So can there be places where we don't see a pleural line? Yes, of course it can be. If you are, while you are scanning the abdomen, I don't know if you guys can see me. Can you guys see me along with my
Yes.
presentation? Yes. Okay. So say this is your probe and you are trying to scan the baby and you come to the lower lung zones, yeah, on R2 areas, or the PLAPS areas. So of course you will be coming over the abdominal, below the diaphragm. So you can see either liver, or you are more towards the medial side, you might be coming over the stomach as well, which happens all the time. And you will not, when you are over the abdomen, you will not see the pleural line. Yeah. And in situations like when you have CDH pathology, where your abdominal content is in the lung, you're not going to see the pleural line again. Yeah, you will see something else. So we have to determine, is there a pleural line, basically, so that we are not dealing with anything else but the lung. Yeah. When we see the pleural line, the next question comes. Okay, I see a pleural line, but is there a pleural sliding? Now, what is pleural sliding? We like to call it as end crawling effect. The simmering movement of the pleura. It just simmers when you try to look at it, focus at it. So it's a simmering movement, and that is because your lung is moving with respiration. Yeah, so air in, air out. So your the parietal and the visceral pleura are rubbing against each other because your lung is moving, yeah, in and out. So the parietal and visceral pleura rubs. When it rubs, it gives, on the ultrasound scanner, that rubbing effect will give you a rubbing motion will give you an end crawling effect, or the simmering effect. Yeah. So that's pleural sliding. So when two pleuras are sliding, what it basically means, there is no pneumothorax, because that's your parietal pleura and that's your visceral pleura. Yeah, you cannot differentiate between the two on the scanner. But if you are seeing sliding, that means the visceral pleura is there and it is sliding against the parietal pleura. So the lung is intact. Make sense? If there is a pneumothorax, boom, the visceral pleura is gone. It's all filled with air now. Yeah. So what you're left with is only the parietal pleura. Yeah, so it's all air now. So you're not going to see any sliding movement because there's no visceral pleura. So if there is no pleural sliding and you see only A lines, you do not see any comet tails, you do not see any P lines, you can make a safe assumption that there is a pneumothorax or an air leak there. Yeah, we'll see those, and we will talk more about it so that we don't make the false positive or false negative diagnosis of this when we talk about the pathologies. But just know that pleural sliding present basically rules out pneumothorax. If it is absent, you have to think about pneumothorax. Yeah. Then we try to look into the A lines. You saw the pleural sliding. Now you try to look at the A lines. Is there A lines present? And again, if you see the A lines, it can be present in normal lung. It can be present in the in the pneumothorax. Then you try to focus on, is there a B lines? You see the B lines. Okay. This segment I'm imaging, there is no pneumothorax in this area. There is no pocket of air. So B lines are present. And then, you can see the comet tail artifacts as well. So if you follow this, each time you scan, you will reach a conclusion with your, with the clinical background you have. And when we talk about the pathologies in the upcoming lectures, I'm going to follow the same thing again and again with you. And you will see that when you're following this with the clinical context in the background, you will come to a conclusion, a diagnosis for that baby you are scanning. Okay, so let's see. Pleural sliding. Is pleural sliding present here? I know it's. Oh, yeah, I can hear you. Yes, there's a pleural sliding present. You can see the simmering effect on the pleura. I'm just focusing here, zooming in. So you can see the simmering effect of the pleura. It's because your parietal and you cannot differentiate parietal and visceral pleura, but you can see the simmering effect. They're rubbing against each other. So basically, it tells you I don't see any cometal lines here in this segment. I cannot see any B lines, but I can safely assume there's a lung there because I can see pleural, pleural sliding. So there's a visceral pleura present there. So this is a normal looking lung with loads of A lines, and in this segment there is no B lines whatsoever. But this is not pneumothorax. This is a normal looking lung. Yeah. So that's what pleural sliding is. Again, on this one, can we see the pleural sliding?
Yes.
Yes, absolutely, we can see. And you can see this is a linear probe I'm using. This is not the hockey stick. And you can see so many lung segments because it's an extremely preterm baby. And you can see the entirety, almost entirety of the lung here. And you can see a beautiful pleural sliding. I'll not go much in detail of what else we are seeing here, but just sticking to the pleural sliding, you can see there's nice simmering effect. You can see the B lines coming in the picture, and there's a pleural sliding present. Right. When do we see absence of pleural sliding? So when we're talking about the pleural sliding, as I explained, if you have a pneumothorax, you lose your visceral pleura. So there is no rubbing effect. There's no rubbing movement. So you lose pleural sliding. Can we see in the pleural effusion? Yes, of course. Where do we have pleural effusion? Is in between the parietal and the visceral pleura. So it's rubbing each other, pleural sliding, fill up with the fluid, no sliding. Yeah, makes sense. So you lose pleural sliding and pleural effusion. We see completely different sign. We're going to talk about that when we talk specifically about pleural effusion. But you can imagine there will be absent of pleural sliding and pleural effusion. In collapse and consolidations, so your parietal pleura, visceral pleura, and now instead of air here, so that you move your, you have this rubbing movement when you inspiring and expiring, the baby is inspiring and expiring. Instead of air now, it has filled up, it has either collapsed, or it has filled up with the gelatinous, exudates here, giving rise to consolidation. Basically, there will not be movement of air in and out. Is it going to move? Well, if it is not severe enough, it might move, but there will be decrease in pleural sliding. If it is severe enough, or if it is a collapse, of course, there's no, in and out movement of the air. So there will be no pleural sliding. It's There's no movement of the visceral pleura, so you lose pleural sliding. In collapses, in atelectasis, baby's been ventilated for quite a long time, and suddenly in the morning you do a gas and you see respiratory acidosis, high CO2s, and you wonder what happened. Baby was doing fine, and suddenly there is a rising respiratory acidosis. You do a chest X-ray, or you can decide to do a lung ultrasound. On chest X-ray, you will see collapse, or you might see consolidation if it is an infectious case. But sticking to collapse or atelectasis, you can do a lung ultrasound and you can see, there's the rest of the lungs looks fine in one particular zone. There is absence of pleural sliding. I don't see A lines there. I can see some bronchograms coming in the picture. So we can conclude that, okay, there is a collapse going on there. Chest tubes. Again, if you have chest tubes are put in, either you have a pneumothorax or a pleural effusion. So if you have either of one, you're going to lose your pleural sliding. Pneumothorax, let's talk more about it. You're going to have absence of pleural sliding. You're going to have A profile. What is A profile? Just coming to that now. So it's absence of B lines and you see only A lines. Yeah, you can see some comital artifacts. Sorry, you cannot see any comital artifacts. Absence of B lines and no comital artifacts. When you interrogate the area with the M mode, one-dimensional interrogation of the lung, you're going to see the barcode or the stratosphere sign. Yeah. And this is kind of pathognomic for pneumothorax. You cannot get this sign in any other pathology. Yeah. It has to be a pneumothorax to get a barcode sign. What it is, which is going to come. And again, lung point is pathognomic. What is lung point? It is a transitional zone between the normal aerated lung and the pneumothorax area. Yeah, the airlick area. And you can imagine it's something like this. Parietal pleura, visceral pleura, normal lung here. So it's sliding. Yeah, sliding. So if it is sliding, you might end up seeing some comital artifacts, and you can see some B lines as well. At the same time, the just adjacent to it is your air pocket. You have a small pneumothorax here. So just a parietal pleura, the lung has collapsed all the way in, and there is no visceral pleura here. So this zone between the normal aerated lung and the airlick pocket is your lung point. Yeah. Right. I have already written and declared it, absent pleural sliding. But some of you might be thinking in the back of your head, oh, hang on a minute, I can see some movement there. It is definitely making some kind of a movement. Can anybody tell me what it is? Is it actually absent pleural sliding, or is it something else going on there?
Is lung pulse?
Yes and no. So lung pulse is basically generated with your, how do I put it? So with the cardiac movements, it's sort of, the propagation of the heartbeat to the lung. So in that case, you will see some kind of a movement there. This is basically, the propagation of the movement of the adjacent normal aerated lung. So you can see, the baby's breathing in and out. You cannot see any of the comital artifacts of B lines. Neither you see any pleural sliding here. So it's definitely a pneumothorax area, but right adjacent to it's a small area, maybe right adjacent to it somewhere, there will be a normal aerated lung, which is give you this, kind of a movement of the lung area here. So no pleural sliding, but it looks like baby's moving, baby's breathing. Yes, of course, baby is breathing. The normal lung is giving you this kind of an false image here. In situations like this, now how can I be 100% sure? I mean, somebody might come and argue, well, how do you say that? Maybe it is, it's a well-aerated lung, there is no B lines, absolutely, zero B lines. We are not seeing any comital artifacts. And I say, this is a normal looking lung. And I'm not pretty convinced that there is no pleural sliding. What will be your answer to that?
M mode.
M mode, excellent. So that's when we interrogate with the M mode. Yeah. So in a situation like always do it, but especially it's helpful in situations like this, where you are like in a double mind, maybe there is some pleural sliding or maybe not, I'm not sure. Let's do an M mode. Okay, I'll show you what the M mode looks like, but just sticking to the absent pleural sliding. Do we have pleural sliding here?
I think this is a mirror shadow artifact.
Yes, we do have a mirror shadow artifact, and there is an absent pleural sliding here. Just focus in that area. Yeah, there's no simmering movement. There's no pleural sliding whatsoever. Yeah.
Have a long point.
This is a lung point. Again, you can see this area. We can see, the B lines, some compact B lines, A lines, pleural sliding. Yeah. Your B lines are moving with respiration. Can you see that? So that's a normal looking lung. And just adjacent to it, there is absent pleural sliding. Nothing is coming out of the pleura because there is no visceral pleura. It's all air filled. And there is no pleural sliding here. So the transition between these two areas is called your lung point. That's a normal looking lung, and that's the air leak on that side. And that is your lung point. And again, how to interrogate with the M mode in that particular instance, we're just going to see that. First, the normal lung. So how the normal lungs looks like on your M mode interrogation. So if you're interrogating the normal lung area, so you're going to see this kind of an image. Yeah, a little bit of darker areas followed by this sandy granular appearance in the most of the rest of the part of their scan. Yeah, this is what we see. And trust me, when you're doing it, as a when you're trying to interrogate some doubtful area with the M mode, when you're doing it, you feel like, am I seeing it as a normal seashore or a sandy beach sign, or is it a stratosphere sign? At times, it becomes quite challenging. It happens to me all the time. And there's a way around to figure out that as well. But trying to see how the normal looks like. So that is why it's called, seashore or a sandy beach. So that particular area is your sky. Again, the radiologists have quite a stretch of imagination. So that's your sea there. Yeah. So that's your sky. That's your sea. That's your horizon. And the granular area is your sandy beach. Yeah. And it looks something like this. I hope it looks like this. So that's what the seashore or sandy beach sign looks like. And just contrary to that, what's the barcode or a stratosphere sign looks like? So I have put a little barcode here, and you can agree that it looks, similar to the barcode. Yeah, some thick lines, some thin lines, some bright areas, and some darker areas. Yeah, so this will be on the area where there is an air leak. Yeah, right. Okay. So that's what the barcode looks like. But when you're doing it for the first time, and say you put the probe on and you hit the M button. If I don't show you this barcode here, and you'll be wondering, am I seeing some sky and sea and sand? You'll be confused. And it's a fair confusion. It happens all the time. So you try to find the lung point and try to interrogate both the areas at the same time. And then you will be able to see how different it looks. So that's a sandy beach sign, and that's a barcode or a stratosphere sign. When you're putting both side by side, you can imagine it looks very, very different now. Make sense? Again, this is the same baby which has got the the normal aerated lung here with the pneumothorax here. So what I'm doing here right now, I'm interrogating first the normal aerated lung, which is giving me this sandy beach sign appearance here. Yeah. And then by the while this image is being generated, just midway, I shifted it to the air leak area, and it gives me this. So you get both the areas. This is a transitional zone. So you get both the areas in the same picture. It becomes easy to compare. It becomes comparative here. Is it making sense?
Yes.
Yeah. Great. So, and then you can see, you can see the transition point, and you see it's quite evident that this is a barcode sign and this is the sandy beach appearance. If you see in isolation, you will always have a doubt that am I seeing the sandy beach here and a sky and a sea and all that? But if you are doing it comparatively in that area of transition, you will see very clearly. And as as you gain experience in seeing this later on, you will know, okay, I'm looking at the barcode or I'm looking at the sandy beach sign. Yeah, you will just know by looking at it. But when you're starting to do it, so this will help you immensely. Right. What happens in collapse and consolidations and atelectasis? I'm just gonna touch base with it. Because we're talking about the signs. So loss of aeration is loss of A lines. You can imagine there will be loss of aeration in collapse, loss of aeration in consolidation, and in atelectasis. The pathology will vary. What is giving you collapse, what is giving you consolidation and atelectasis, there will be different pathology, and the clinical background will guide you on that. But what the signs you're gonna see will always remain the same. Yeah. So loss of aeration is loss of A lines. If you have an alveolar or interstitial edema, developing edema, you're gonna see emergence followed by, depending on how the baby has progressed or how worse the baby has become in terms of the edema, you will see abundance of the B lines leading to the compact B lines. We will see air fluid bronchograms. I'll not stress on it today much. When we talk about pathology, we're going to deal in depth with this. But we see something called a static and either static or dynamic air fluid bronchograms. There will be disrupted or irregular pleural line, again, which is called as a shred sign, because when we see the pleural line, we always ask the question, are we seeing the pleural line? Yes, we are seeing the pleural line. Second, is it regular, irregular? Oh, it is irregular. Now, why your pleural line is becoming irregular? Maybe you are dealing with some consolidations there, you're having some collapses there, is giving you the shred sign. So we're going to talk about those things. And the loss of pleural sliding will be there in collapse, consolidation, and atelectasis. When I say loss, don't take it too dogmatically. In collapse, it depends on what is the degree, or in it consolidation, it depends on what is the degree of consolidation. If it is just the beginning of this pathology and the area is is getting consolidated, the process is started, you can still have some pleural sliding, but it will not be the best pleural sliding. So there will be paucity or reduced pleural sliding. And by the time it is fully mature consolidation, thick, there's no air movement at all, absolute loss of pleural sliding. And then you can get a lung pulse. So again, as I said, lung pulse is a transmitted cardiac pulse. And it's a good how you can see the lung pulse. I'll show you when you do the M mode, you will see it coincides with the heartbeat of the baby and the heart rate of the baby. So you can see lung pulse. Of course, you can see lung pulse in your air leak transitional areas. You can see lung pulse in consolidated areas, because that area, you can imagine that area has become quite solid. Yeah. So now it's not moving normally with the breathing movement. Rather, this solid area is transmitting whatever is beating around it. Yeah. So that's how you get the lung pulse. And again, sorry about this. I don't know what I'm doing with my system here. It's going back and forth. Again, let's not dwell too much on bronchograms and stretch sign, because it will be too much for one single session. And we're going to deal with this when we talk about the particular pathologies. I'm going to revisit this again there. But just know that you do see bronchograms and the stretch sign when you're dealing with the collapse, atelectasis, and consolidations. Yeah. I'm just gonna I'm not talking about the shred sign and all that in today's lecture. I beg your pardon. I've still kept the slide here, but why I don't want to talk today is because I don't want to muddy the water, and not to confuse you people. And so I'm just gonna skip that. Oh. Let's see if I'm on the right slides. Right now, pattern recognition. So far we have talked about all the signs now. So let's recognize the patterns now. You can see this is a prime profile. So there is a profile and there is a prime profile. So what's the difference between the A profile and the A prime profile? The absence of B lines or the committal artifacts. If you are seeing A lines and at the same time you see normal, 3 to 5 B lines, or you are seeing committal artifacts, it is called A profile. If you see only A lines and you do not see any other vertical reverberation artifacts, then it is called A prime profile. Where do we see A prime profile? Is in pneumothorax, is in air leaks. You can see here. Do we see the pleural line? Yes, we see the pleural line, quite bright, discrete, and regular. Is there a pleural sliding? Second question. No, I don't see any simmering effect here. There's no movement whatsoever. So, and I don't see any comet tails coming from here, or neither do I see any B lines reaching all the way to the bottom of the screen. Yeah. So this constitutes the A prime profile. You will see this profile when you see when you are doing scan for the pneumothorax, or if you see this profile, you know it's a pneumothorax area. Again, similar picture here. You can see the first question, is there a pleural line? Yes. You can see the bat sign as well. That's your rib shadowing. So bat sign is present. So you are right bang on top, 90-degree over the pleural line with your probe. Now, is there a pleural line? Yes. Bright, discrete, regular. Do we see, A lines? Yes. Equidistant. You can see A lines coming here. Do I see comet tail artifacts? No. Do I see any B lines? No. So if you don't see those, you're seeing only A lines and absent of pleural sliding A prime profile. Now move to the A profile. So this is how different it looks. Can you see? So again, first question, bat sign. Do we have a bat sign? Absolutely. Those are the rib shadowing. Yeah. And then you have, can you see the pleural line? Yes. Nice, bright, discrete, regular. It's not broken. So pleural line is there, smooth and discrete. Can I see the pleural sliding? Yes, of course. I mean, there's a plenty of evidence. You can see B lines reaching all the way to the bottom of the screen, and it is moving with the respiration, inspiration and expiration. And your B lines comes in. So as you are expiring, your air goes out. So you end up having more fluid, inspiration, more air, you lose B lines, expiration, more of less air and more fluid now. So you end up generating B lines, and that's what is happening in this baby. It comes and goes, normal appearing A profile. Yeah. Similar kind of a picture here. Bat wing, pleura, yes. Pleural sliding, yes. I can see some comet tail artifacts. Yeah, just ending here. And I think there's one B line reaching all the way to the bottom of the screen. So A profile, you can see the pleural sliding. Again, to show you A prime, just to make you accustomed how it looks differently, you can see again, it is a kind of a movement you're getting for the adjacent normal lung there. So you can see the breathing movement, but is there a pleural sliding? No. Now you are convinced there is no pleural sliding here, without doing the M mode. So no pleural sliding, only A lines. I don't see any comet tail or B lines here. A prime profile. I'm not going to talk about the AB profile. The reason for this is what we have seen, or when we are teaching lung ultrasound to the trainees here, it confuses people. So A profile, and then there's a B profile, and then what is a B profile? So it confuses people immensely. But just as a passing statement for the AB profile, it's a mixture of when you're seeing a normal A profile and a normal B profile, and you can see both the profile in the same segment, you try to call it as an AB profile. Yeah. Um, um, some of the literature, they do not, in the literature, some of the papers I've seen, they do not specifically talk about the AB profile. The earlier literature, when we were starting of the lung ultrasound, it was used very commonly, the AB profile. But then as we are learning more, we are trying to avoid this name. But for the sake of this, understanding here, just know that AB profile is a mixture between a normal A and a normal B profile, if you're seeing both the things on the same segment. But I will not dwell much on the AB profile. Coming to the B profile. So what's B profile? Now, again, it's quite a didactic kind of a lecture we are having here. So I usually like to engage with people and ask a lot of questions. I can't do that right now over here. But my question in this would have been like, what are we seeing here? Again, from the same stepwise approach. Bat wing sign, you can see the ribs. You can see the rib shadowing, acoustic shadowing. So the bat wing sign is present. So we are bang on top, 90-degree angle with the pleural lines. So there is no question that if I'm going to move, we would have seen better A lines or, less of B lines and all that. So we are seeing what we are seeing, and we're going to interpret this image. Can I see the pleural line? Well, do anybody wants to come in on that? Okay, so the second question is, the next question is, do I see the pleural line? Well, you can say, well, I can see some, brightness to begin with, but I cannot see a discrete, regular pleural line. That's how you can describe this image. This is not discrete, yes, and it is not what do you call it? It has more kind of a smudged effect. It is something like, somebody has put an ink there and smudged it, or put a finger there on this pleural line and smudged it. So this is basically the coalescent B lines or the compact B lines looks like. Yeah. And as I said, B lines always erases the A lines. So when it has become compact, you cannot see any A lines here. But when baby inspires, at the peak of the inspiration, there's some A lines appears. If you see what I mean, just focus here, follow my probe. At the peak of the inspiration, because a lot of air has moved in, so you can see some A lines there. But most of the time, it's just B lines, and it erases the A lines. Yeah. So this kind of a profile is B profile. Yeah. So you're not seeing A lines. It's predominantly, well, completely, compact B lines. So that's your B profile. Hope that is making sense so far. Again, this, some people would say, oh, I can see some A lines, A profile. I can see some B lines, B profile. Let's call it as an A, B profile. So it creates confusion. Here, the B lines there. Yeah. Isn't it? It's a lot of B lines coming out of here. So B profile, I wouldn't say that as an A profile here. Yeah. And I will refrain calling it as an A-B profile, because you will see that when we are talking about the RDS, we are talking about the TTN, you will see this kind of a picture a lot more time. And then, yeah, it sort of it sort of muddy the picture basically. So when you're talking AB profile and all that, we better use the scoring system to come into conclusion in those pathologies. But nonetheless, that's a B profile. One more sign I wanted to talk about, because RDS is bread and butter of neonatology, and your lung ultrasound is immensely helpful to differentiate between TTN and RDS. And this is the first thing, the pneumothorax is one, normal lung, and then try, able to differentiate TT and RDS will give you immense pleasure. Like you can see, oh, we are 100% right. This is what it is, and we are making a difference. So this sign becomes quite important here. So we have talked a lot about pneumothorax. We don't want to miss that. We have seen normal lung, and going to that territory of TT and RDS comes this double lung point. So what is a double lung point? Of course, in a one segment, you cannot have two lungs. It's just one lung. But double lung point basically means you are seeing two kind of a profile. Yeah, two kind of a profile in one zone of the lung, not one segment, one zone of the lung. Say you are doing R1, R2. I'm sure Alok must have gone through the, the topography of the lung and how you name different zones of the lung. There's a small variation, and depending on which part of the world you are, but it's pretty simple. Whichever terminologies zoning method you use. So in one zone, say suppose you are doing in this particular baby, we have this baby is put prone, so right area, right zone, prone position, the zone 2, so RP2. In that sector, you can see in that zone, I see two profiles here. If I say here, this part of the lung, I don't know if it is clear to you guys on your screen, but you can see A lines and 3 to 5 B lines coming in here, like a normal lung. Yeah, so that's a profile. Yeah, that's a profile. Whereas here you can see you cannot see any A lines, can we? We smudged effect of the pleural line and the compact B lines coming in the picture. So B profile. Yeah. And again, I refrain from using A-B profile because of this very reason. So somebody might say, okay, I see A profile here, B profile here in this zone. Can we call it as an A-B profile? Well, no, don't say that. So this is double lung point. So one lung well aerated and the basal part of the lung is quite dense. When you see this kind of a picture, you can be pretty much sure that this is this baby, or you are dealing with TTN as a pathology. Yeah, you don't have to jump onto the surfactant. You can sit on tight with the CPAP, give some more time to the baby, and be rest assured that baby will turn corners and can do very well without the surfactant. Yeah, so double lung point, if you see, that is more indicative. I would not say pathognomic. We used to think it is pathognomic, but it is not. So I would not say it is pathognomic of TTN, but is it's very much indicative of TTN. Yeah. So so that's what double lung point is. How it is different, why it is not pathognomic and all that. When we talk about RDS, when we talk about TTN, we will go into the details of that. How we differentiate TTN from RDS using double lung point and what other signs are there. So we're going to talk there. But double lung point, when you see, you think, we might be dealing with TTN here. Yeah, and just to add few more points here, if it is because of if you are dealing with RDS, because it is a homogeneous disease, you cannot have a lung area where there is surfactant and there is a lung area you are not having a surfactant. That doesn't work that way. The RDS, it's a global surfactant deficiency. When you have a global surfactant deficiency, why would you have an area which is in a lung, a part of an area which is well aerated and a part of area which is dense? Logically or pathologically, it can only be explained by TTN. A part of an area has more fluid than the well aerated part of that lung. Yeah, so it indicates more towards the TTN. Right. Moving on. Yeah, my clumsy animation there. A profile, B profile, and a double lung point. Right. Again. Similar kind of a picture here. So B profile and kind of a profile. You see more of a line here, A lines here, and at the peak of the expiration, some B lines comes in this area, whereas this part, the basal part of the lung, it's quite dense. Yeah, this is from the same baby. The previous one was RP2 zone, and this is from the LP2 zone. Yeah, so you can see that the upper apical part of the lung is well aerated and the basal part is quite dense. Again, which indicates more towards the TTN pathology. Yeah. Right. Okay. Moving on. This is another double lung point. Again, try to recognize the pattern here, see how it looks like. And the more you see, it will etched in your memory, and you know that, this is what we are dealing with. This is the double lung point. Well aerated area. Again, don't lose the this systematic approach. So always go by your batwing sign. You can see the batwing sign with the ribs shadowing. Is there a pleural line? Yes, nice and discreet here, a bit of smudged appearance. And then we do see A lines. Is there a pleural sliding? Yes, there's a pleural sliding in entirety. Even in the B profile area where you cannot count the B lines, it's all compact, but you can see the simmering effect on the pleural line. So the sliding is present. And then what A lines you see, how many B lines you see, and that's how you define your profiles. So A profile and B profile, that's the double lung point. Okay. Same here.
Abhijit,
Yes.
we just because we're hitting nearly 2 hours, I think what we can do is do the C profile and then we'll stop here.
This is the end of it. So I'm just at my last slide now. Hello. Yeah. So I haven't put anything on a C profile because I don't wanted to touch on the C profile today because I feel it will be too much to, for a one session to go on to. And we're going to deal with this anyway when we talk about the, pathologies. I haven't done all the signs of, collapse consolidations. I have touched with the name, but we haven't gone in detail of those. So we're going to do that when we talk about those pathologies. Yeah. So this is the end here. So I'll leave it that, and
So folks,
I'm happy to take any questions.
yeah, I was gonna say, just because I'm gonna
Yeah.
run out of data on my computer,
Right.
we have time for maybe one or two quick questions. So any questions, you can just put your hand up.
Oh, I
Yes,
can't see.
please. The comet tail is a Z line for
Sorry, your voice is not clear.
the
Can you come
comet tail. The comet tail. It is a Z line.
Is the comet tail B line is a question?
لا, Z line.
The Z
Z.
line.
Yeah.
No. And that's the reason I have not gone on, I have not gone onto the Z lines and all that. I want to keep it very pragmatic when it comes to the lung ultrasound when we start to do it. And we can talk about Z lines and all that. It will give you more of a pathophysiological way of a kind of giving you, how those lines are created, how your ultrasound waves is playing around with your, air fluid interface. We can talk all about that. But the kind of information you're going to gather out of it is very minimal in context of getting to the diagnosis of the baby. So, and when you are learning it, bringing on those lines, right, with the A and B lines and, comet tails, sort of complicates the picture. It's too much to come to the diagnosis. So I will stick to A lines, B lines, comet tail artifacts, and the pattern recognition to begin with. And as we progresses with the pathologies, yes, we can definitely touch upon it. But answering a question, is the Z lines is a comet tail artifacts? No.
Any other questions?
You can add the pleural adhesion to absent lung sliding.
In pleural adhesions,
Yeah.
yes.
So yeah.
Yes. Yes, in pleural adhesions, you will have absent lung sliding. As I said, so we deal with, pneumothorax, pleural effusions, and those kind of pathologies. Ended up putting a chest tube, and later on we have seen that because of this repeated pleural effusion, ended up getting adhesiolysis and all. Fibrinolytic treatment over there. End up getting pleural adhesion on those babies, and we try to look into those areas with the lung ultrasound. And yes, you don't see that classical pleural sliding over there. No.
Last thing, please. The when you your slide, You are writing RB2 or LB2. What mean by
Mhm.
that then?
The nomenclature. So
I
don't
was
know if I
gonna
had the
say we'll stick to the nomenclature that we're learning in our course at the moment, because the
yes.
guidelines that I provide to you, that we use that
Okay.
specific nomenclature. At the end of
Mhm.
it, I would say is rather than get too wound up, because what you'll find is every institute, I think if you work in the UK, the guideline changes every 40 miles. I
Yeah.
think for us, what is important is that you develop your standardized nomenclature for your institute using the 6 and the 12 region method as per the size of the baby. And you use nomenclature as you develop locally to try and identify them so that when you're reporting the scan, you're using the same nomenclature. I
Okay.
Yeah.
also echo Abhijit's opinion. Uh, there is an alphabet from A to Z, Z1, Z2. Keep it simple, guys. Keep it simple. The more complicated you make things for yourself, the more difficult you will find interpretation. For neonatology, I think what Abhijit has described today is really the bread and butter of what you need to know. Even if you want to do a PhD in lung ultrasound, keep it as simple as possible. The more complicated you make it, you want to learn what pseudo B lines are, you want to learn what pseudo Z lines are and Z lines are. For us, actually, they're pretty useless. And in essence, the problem with trying to learn and keep an eye on those things is bringing in a lot of confusion to how you will interpret pattern recognition with common pathology. So keep it very, very simple. One last question. So we have a few more. Uh,
Mhm.
can you share the step-by-step approach slide again? Yep, I will do that. So that won't be a problem. Not done M mode before. Is this the M mode button on the G machine? That's correct. Yes. It's
Yeah.
So if you have gone through pattern recognition, it's absolutely mandatory that when you're doing a segment, if you're saying this with sliding, that you verify that using M mode, and that if you're worried there's no total sliding, that you look at it again.
Sorry,
Any
Alok, you're
okay.
breaking up. I couldn't get the whole question.
So the question was, when would you use M mode?
When do we use M mode?
Yeah.
Okay, so again, first of all, it's the baby we are trying to, at the pathology we are trying to find out. So the clinical context, clinical background, why you have been approached, or why do you think you need to do the lung ultrasound? Number one. Number two, if you are thinking that it might be a case of a pneumothorax, you're not being able to, find, sort of think of what pathology you're dealing with. You try to go and scan the area. Systematic approach. So if you do see pleural line, yes, you are on the lung. You see the bat wing sign, you are on the lung. Pleural sliding. If you have any doubt in any segment or any zone, you are scanning. If you're having a doubt about pleural sliding, use the M mode. Yeah. As I said, the pleural sliding might be, there will be a paucity of pleural sliding. There will be altogether absence of pleural sliding. You don't know. It depends on what pathology you're dealing with. If it is a pneumothorax, no pleural sliding at all. If it is a collapse consolidation in that area, you might have some paucity of pleural sliding, or again, might not be any pleural sliding at all. So any doubt about pleural sliding, use M mode. Interrogate with the M mode to get the answer. I hope that answers the question.
Yep. Yes. So Asian has asked a question. Uh, will you see the seashore sign on a B profile if there's pleural sliding? Answer is
Do we see? Yes, yes, absolutely. Absolutely. So any lung pathology, okay, I'll give you an extension of that further. So if it is a B profile, compact B line, severe RDS baby, and you are trying to do M mode, do I see a seashore sign or a sandy beach sign? Yes, I do. If it is a baby who has got a collapse consolidation, and there is a paucity of pleural sliding, I'm not very sure that there is a pleural sliding, and I try to interrogate with the M mode. Do I see a seashore sign? Yes, I do. So you will you will only see barcode or a stratosphere sign in pneumothorax. There might be a paucity of pleural sliding, as I said, in collapse consolidated areas. So you you will see some variance of a what you call seashore sign there, but you will never see a stratosphere sign over there. Yeah, why we don't generate a stratosphere sign even there is even if there is literally no movement in collapse consolidated areas, that's altogether a different discussion, and that's how the ultrasound works. But no, if there is no pneumothorax, you do see seashore or sandy beach sign.
Lovely. I'm going to thank Abhijit. That was a fantastic marathon of a talk. I will edit this video. It's over 2 hours. This will take me at least 48 hours to edit before I can get it into your boxes. So just give me some time. More importantly, what I'd say is I will share the step-by-step approach that Abhijit has spoken about today, that I've emphasized in the last lecture, so that you can all have a look at it. God bless you all. Have a good evening. Thank you.
Thank you, Alok. Thank you so much. And apologies, I overshoot time.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
God bless you.
Thank you.